Good evening. Welcome to Body Garage on TV 47, where your health matters. On this episode, we delve into irregular heartbeats. What are its causes, symptoms, risks, and how can you prevent it? Taking us through it is Dr. Dan Gikonyo of the Karen Hospital. Come with me. By that name, I think it means rhythm or something. What is it?
That's correct. You know, the word is rhythm, that's the generic name. Arrhythmia means lack of rhythm, like absence
Of the rhythm.
Yeah, the rhythm is no longer there. The heart should have a perfect rhythm where it beats like somebody on a marching. It goes pum, 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 pum. About 50 to 80 times every minute. The number 72 is just a number you have taken as an average, but there is this belief, which is not correct, that your heart must beat at 72 per minute. No, it doesn't do that. There is nobody whose heart beats at 72 times per minute all the time. It varies. Sometimes you're beating at 55, 60, 75, 80. There. It's when it gets out of that average that we get concerned about.
So then this irregular heartbeats, what causes it?
Now, as we said, the heart must be regular, like soldiers like marching soldiers with a drum. But like all machines, and the heart is just one of God's beautiful machines that He has given us in the body, something can go wrong, in the sense that the timer that times that rhythm can be out of time, and then becomes irregular. So sometimes that can happen, and many of the times our hearts are a bit irregular, near all of us. But you don't notice it. These are normal variations in rhythm, especially in young people. You can have a young person whose heart is beating irregularly. We call it sinus arrhythmia. It is still normal, but does not keep the rhythm. That's very normal in young people, irregularity in the rhythm. But it's when it becomes an issue that can create disease in the body that we get concerned. That's much more common in older people. The heart either starts beating too fast or too slow, or both combined. And those ones are the ones we need to analyze and see, are they dangerous? Do you have an issue? Do we need to get you to see a doctor, a heart doctor? Do we need to do something about it?
Sometimes in a child, when you hear the heartbeat, it like goes so fast and it's fast. And is that irregular for a child?
The heart rate in children is usually higher than adults. So a newborn, even if they are going at a rate of 90, 100, it's still normal. As you get older, the heart rate stabilizes. The numbers you have said between maybe 60 and 80, they're in between. So we don't worry so much until that heart rhythm either has symptoms or is noted to be the type that give you problems. There's one condition which we must talk about called atrial fibrillation. The heart has 4 chambers. 2 upstairs, called the atrium, 2 below, called the ventricles. The ventricles are the receivers of blood from the atria. Then they pump it. One on the right pumps the lung, one on the left pumps the body. The heartbeat starts from the top of those upper chambers as an electrical current. How does the heart know how to beat? You know, we all have our own little, we call timekeepers, our own little natural pacemakers. You know, a pacemaker that gives the pace.
Yeah.
We all have if I show you this heart, let's just go through this heart. If you allow me, I'll take this away a little bit.
All right.
This can be seen. So I'll put back this cover. This is the heart as it looks. That's a normal heart. That's how it looks from outside. And these little vessels on top are what we call the coronary arteries. These are the ones that feed the heart muscle with blood. Because the heart, although it's a pump, it also requires blood to its muscle to work. So you have these little blood vessels on top, just like you have blood vessels on top of your hand that feed the heart. you have these vessels on top of the heart that feed the heart. They are called the coronary arteries. These are the ones, if they get blocked, you get a heart attack. But today we are on the issue of the heart rhythm. So these vessels sit on the top here, and they are the ones that supply blood to the rest of the body. This red one is called the aorta, takes blood to the body. This blue one is the pulmonary artery. So blood from the right side comes out through here to the lungs.
Yes.
Comes back here, it's pumped by this left side through the aorta to the rest of the body. So I will remove those one now, and also remove this top cover. So we are now inside the heart. And in this heart, these upper chambers are called the atria, these two. These lower chambers are called the ventricles.
Okay.
And between the upper and lower chambers is a valve. The one on the right is called the, one on the right, let me go backwards. Yeah, the one on the right, this one, is called the tricuspid valve. Because there are three cusps. Tri means three. Three cusps and two cusps. Tricuspid and the bicuspid. The bicuspid is well known as the mitral. Left atrium, right atrium. Right ventricle, left ventricle. So for the muscle to pump, we must give it a signal. And that signal is electrical. And it starts from very high up here at a place we call the sinus node. That's the natural pacemaker of the heart. It is up here. And it generates electricity. It's a biological battery. Every second or so, it sends a burst of current. That current spreads to these muscles. As it gets to this red part of the heart, the muscles, when they get that current, they will constrict. That's how the muscles of the body react all the time. If you touch electricity, your heart will jump, your hand will jump. So even here, when the current gets onto these muscles, it will contract.
Yes.
Then the current is finished, it relaxes. It waits for the next round of burst of electricity to make it pump. So it is this pacemaker, natural one, that fires the heart 70 times or so in a minute. And that's regular. If this pacemaker, where the current is starting, goes bad, and it's just wear and tear, anything can go here. Even your bulb, you come tomorrow in the evening, you switch on, it doesn't go on. Nobody has touched it, just worn out. It's a phenomenon of time. So even as we get older, this pacemaker can go wrong. But more important, as the current flows to these chambers, it has pathways, it has lines, like electrical lines. That's the lines of electricity, the wires. They are biological, you can't see them, but they are there, where the current travels to go to the muscle. Those wires also can wear out, and they can stop conducting that current. It is that whole system of the natural pacemaker and the lines that take current that can go wrong, that gives you an abnormal heart rate. So if it, for example, if it goes too fast, the heart will start going. If it goes slow.
Okay. And you know, when you tell somebody you have an irregular heartbeat, they'll be shocked first. How serious is it?
Now, the heartbeat, we worry if it gives you symptoms. Number one. For example, if you don't get a good heartbeat and the blood therefore does not get to your brain, you'll feel dizzy. And sometimes you might even faint. So fainting is one of the things we worry about. Somebody says they are fainting, you worry. Is it a rhythm of the heart? You can faint from many other conditions. But one of the conditions that make you faint is an irregular heartbeat. However, I want to remove the anxiety from people who faint, because in reality, you are allowed one faint in your life. So if you fainted in a wedding or in a funeral or in an exam, don't panic. One time you're allowed. We worry when that becomes repeated or you get near fainting episodes. So anybody who gets recurrent episodes of near fainting should come for a check, because it could be from that irregular heartbeat that is causing poor blood supply to the brain, and therefore you pass out.
Okay. So what other symptoms should I look out for as well?
What most people complain about is they'll come and tell you, I can feel my heart beating too fast.
Yes.
You know, normally as you see there, Sheila, you don't feel your heart.
I don't feel it.
You don't even know you have a heart. I know you have.
I can't feel it.
No, your friends know you have a good heart.
Yes.
But normally you don't feel your heart because it's like a good engine. You switch on, no noise, just goes very soft. So the heartbeat in a normal person is not noticeable. You don't feel it.
Mm-hmm.
If you can sense that your heart is pumping in your chest, you can feel it moving, there's something wrong with that heart.
Mm-hmm.
So that's one. The sensation of a heartbeat, which in English we call palpitation, is one sign that the heart has an issue in its beating, in its rhythm. The other one is what you have said, when you get to a point of either fainting or you are near fainting, you get dizzy and you have to, then that also could be a sign that the heartbeat is not normal. Mm-hmm. So people who should get concerned are people who feel you can sense your heart and then you feel dizzy. That's a bad sign. You should see a doctor. However, as we keep saying, don't wait until all those things come to you. If you are 40, 45, 50, going upwards, once a year, please go see a doctor. Yeah, it's just for normal routine maintenance, yeah, so that you feel comfortable that I've had my check, I'm okay. Somebody check my sugar, my blood pressure, my weight, my cholesterol, my kidney function. Once a year after the age of 45, you'll be okay. But however, even if you do that, you feel those things, you have not done your checkup, you feel those things, you should come and get a wellness. Here in Karen Hospital, we offer wellness checks. Where people just come in at the door, they don't even enter the hospital. There's a department where you just come and get your wellness checked. And we do all those things. We check your cholesterol, we check your sugar, we check your blood pressure, we check your weight. We advise you about cigarette smoking, we advise you about exercise, we advise you about healthy diet once a year.
And how common is this disease in people?
The irregular heartbeat?
Yes.
Irregular heartbeats are very, very common. I think they are more common by symptom rather than disease. Because many people feel an irregular heartbeat, but not all of them are dangerous. But once you have an irregular heartbeat, you should get what is called an ECG. It's a recording of your heart over a period of maybe 10 seconds. It will draw those lines. And you'll see, are those lines regular? Are they irregular? Are they following each other? Do they have the normal electrical pattern? That will tell us. However, when you come and you do an ECG, we'll do it when you are feeling well. You may be feeling bad at home, like fainting. When you come, you do a resting ECG, it's normal. It does not mean you are normal, because it could be that when you get home, you're not here, you get the irregular heartbeat. So there are tests we do that you take home that check your heartbeat even away from the doctor.
All right, so we have learnt about the symptoms, and now we take a short commercial break, but when we'll be back, we'll look at some of the tests that are taken for this particular irregular heartbeats. Do stay with us. Welcome back. Thank you for staying with Body Garage. Today we focus on irregular heartbeats. And before the break, Dr. Dan Gikonyo did give us some of the causes, what exactly is irregular heartbeats, as well as some of the symptoms that people face. And so on this segment, we meet lovely Caroline. How are you?
I'm good.
Introduce yourself.
Oh, thank you so much. My name is Caroline Wangoi Maina. I'm a clinician, but a clinician with a HND in cardiology. I work hand in hand with Dr. DK, which is an honor, and I'm quite humbled because I've learned a lot.
All right.
Yes.
Now we have our dummy patient here. You had mentioned now, what was this procedure?
It's called a Holter monitor.
A Holter monitor?
Yes.
What does it do?
So a Holter monitor is a 24-hour ECG. So we place it on the patient, and once we've placed it, it starts recording like immediately. Like this one has the potential to start recording on skin contact. Like immediately you place it. So from there it will record the ECGs all along. And the good thing about this, it's not limiting, it's quite a small device. As you can see, it's quite small.
Oh,
yeah?
just that?
Yeah, just that. So these are the leads, just the way we had the leads on the patient earlier on. But now we need to do something that is more, that he can walk around with, that he can do normal things with. And the idea behind it is for him not to just stay still, to continue doing his daily activities, so that we see how does this heart behave during rest, during eating, while if he wants to take a walk, if he goes to the shamba, all those things, and then we can have an overview of how his heart will behave in the next 24 hours. Yeah.
Now, for 24 hours, I'd have almost those 5 nodes on my skin.
Oh, yes.
Why are they 5?
There are 5 because, one, we need to get the electrical activity from, the way Dr. had explained, the chambers. Okay. So there is the ones that we are getting, because the electrical system of the heart flows from the right atrium, which is at the topmost, and then flows to the what we call the AV node, and then to the rest of the heart. So we need to have them in strategic locations where it can get the rhythm all the way to the bottom and to all the chambers. So that's why we have them placed strategically there to get enough data.
Right.
Yeah.
To show us how you would do it.
Yeah. So this is the gadget.
Okay.
We are lucky enough to have some of the latest gadgets in the country. So this one is waterproof, and as well it has better technology than what we've had in the past. Yeah. So it's quite simple. It has this goes to the middle, and then these other 2 will go to the respective chambers, as I will put on our patient now.
Right.
Okay.
So
when I place the yellow one here, there, that's supposed to go to the LA, and then the right atrium there.
Atrium.
Yes, and then these ones ought to mimic the limb leads, because we can't put it on the limbs, so we just put it there, and then you can have this one here, and then finally we can have it. This one will go to the center, what we call the sternum. Yeah, it's at the center of everything, and then it will be there. So we normally secure it with more tape, as he goes home, yeah, so that we make sure it doesn't come off, because 24 hours is quite a while, and he will sleep, and he will turn, and he will do so many other things. So it's like that. And maybe it has picked or not, but there's a sound that has come from the machine.
Yes, I've heard it.
Immediately, I've just placed the last lead. It has the potential to start recording immediately the skin contact. So now it's recording his heart activity, sorry. So for the next 24 hours, if we place this on him, it will record, and then we can have the data tomorrow, which we download on our systems there. And then now the process of downloading is another process, and the interpretation. But now, just before I put it on him, off the record, I had already set up. So you need to set it up prior, correct settings, and then put it on him, and then later when it comes back, you now download and start the interpretation.
So he can go home and continue with his life.
He can go on a matatu, he can drive, he can just do however he carries on with his life. He can do that.
What about showering?
Initially we had ones that you cannot have them get in contact with water, but even this one, as much as it's waterproof, would want him just not to put it in water like that, but he can just have a sponge bath. Yes, and then bring it.
And that's it. So what would he expect to get at the end of having this for 24 hours? So
now there are those indications that we usually have initially. Before he presented to us, probably he came in and told, oh, Dr. my heart is beating too fast. We call that palpitations. Oh, I cannot be able to, or whatever he presented with. And then we saw it fit to fix a halter on him. So now at the end of the day, he expects that we will have a diagnosis for him. Probably we had also done ECG echo before we put the halter. So in combination to that, we will have a diagnosis. Sometimes we'll just put it alone, depending on the indication. And at the end of it, he will have the results, and we'll tell him we can prescribe drugs, we can recommend other procedures, and at times we can just reassure. Worry not, all is well. Yes.
So for you, at the end of the 24 hours as the doctor, what would you be looking out for?
At the end of the 24 hours, for the strips, there are many. It's something that you'll sit down for probably 15, 20, 30 minutes and have a look at it, because it's pages and pages of recordings. But you'll be looking at the rhythm. Did it change at any particular point? Were there something we call arrhythmias? Arrhythmia, when you add A in front of a medical word, usually mean abnormal. So is it deviating from the norm? So, and if it's deviating from the norm, in what manner? So you can get so many things, PVCs, PACs. You can have him occasionally if he had gone into VTAC and all that. So you look at that. How frequent did it occur? Was it significant? And with that, you can be able to say, I'm going to introduce this kind of treatment. I'm going to do this to the client. Yes.
You had mentioned that this is one of the latest that is in the market.
Yeah.
How different is it with the old ones?
Oh, yeah. So now the ones that we had earlier on were a bit hefty, but we still manage and we still use them. You know, not so many people are even lucky to have those old ones. So the old ones needed you to take more time and sit and read and go through everything. Now these ones have an AI, so where it can do a summary, but still the human mind is needed. Yeah. So you incorporate the knowledge that the AI has given you, the highlights, and then you decide, is this true? Is it relevant? Is it? And then now from there, you move forward and see, yeah, so this is better. Yeah.
All right. So now, once he has this, he can go home.
Yeah, he can go home and then come tomorrow, and then we'll remove it from him.
The information would be stored where?
Inside this gadget is there is memory, inbuilt memory, not external like the one we put a memory card. So it has inbuilt memory, and as you can see, it has a USB port. So this one, if you take it and put it on the machine, as you're downloading, as you're setting up, it's charging automatically. So most of the time, it's 90% of charge. And memory, it has a lot of memory, because this data is in probably kilobytes. So it has quite a big space. It can take data and data for several patients. Yes.
So does a patient, you use this once on a patient and throw it away, or?
No, what we change are the leads.
The leads.
Yes, we can change. This is what we change. But the gadget cannot be thrown away. Yes, that one can serve us for years and years. And then, you know, we also have an inbuilt system for the same, which records the data. So even if at one point this gadget gets full and the memory is full and I erase, I still have the data stored there, even if it was for the very first patient that we installed the gadget on.
We assume the patient has come back. How do you remove them?
Okay.
Patient.
So now once the patient is back, sometimes we'll ask if the beeping has been continuing. There's like a small heart drawn here. So as it records, it continuously beeps. But in most of the cases, it has recorded, and you check if the beeping is still there. That shows you that it is still recording even up to now.
Okay.
So ideally, you just get off the leads.
But the beeping is not something itani sumbua. It's not something that will be annoying.
No, you can't even see it. After the first beep, I'm the only one who can now look at this and see that heart has some light.
Oh,
it's not something that will even make you not sleep or not even continue. You will not even notice it. Yeah, so you remove the leads. Yeah.
Just like that.
Just like that. And once it's off him, just the way it had skin contact and started recording, now it has stopped, because it's no longer on human body.
All right.
Yes. So now we have the data, and then we proceed now to download and see how now it has behaved on him.
On this segment of technology and medicine, Caro takes us through the different generations of the echo machine. So which one came first?
So ideally, all of them are echo machines. But now it's the way we have generations. Even your family, you have your great-grandfather, then grandpa, then dad, and here you are. So this one was the oldest. It's the one from the 80s. Yeah. And you can even tell, you can see it used to use VHS. Yeah. So they used to take images, but like the others, it still has probes. The probes are the ones that you place on the patient for you to get images. But now its way of recording was through the VHS. But still, they could get images. If you were to put it on, you'll see it. I don't know if to ask you if you ever encounter the Great Wall telly.
Don't dare.
you see something like
Yeah,
that
yeah.
here, yeah. But still, they'll get images. It had something we call a probe, a very long one that we used to do transesophageal echoes. Echoes cannot only be done on the chest. You can as well put via the esophagus and get a better view of the heart. So it still had that, but now was a little bit not that advanced with so many buttons.
Yes.
And yeah, so this was it.
So
at
does it
that
still
time.
work?
Yes,
right now?
it still works. Yeah, but now it used to use thermoprint. You know thermoprint? You've been in an ultrasound, like the ones they do for pregnant women, the obstetric ultrasounds. So that film is what we call the thermoprint.
Okay.
So that's what it used to do. And then now you have to go and do the report on the side. And that time I asked Doc about it, and he told me he had to handwrite it or type, the typewriter.
yes.
Yes, and then now that's how you used to complete an echo back then.
Now there was an upgrade.
Yes, that was an upgrade. This was a little bit better because now this can accommodate a flash disk. So it makes your work a little bit easier. Still a little bit big in size, but much more better, more clearer. The images are better. 2D, has color flow Doppler, and M mode, and yeah, this is a little bit advanced than where we are from.
And then came now the digital.
Now then came the digital. Yeah, this is the one that is currently what we're having and using. This one is way better. It's faster. The color Dopplers are better. The M mode is better. You can do something called tissue Doppler with it to enhance the measurements. So ideally, you could still get what you can get from here and there and here, but the difference is now here you get to do more detail. It's, for example, let me just use some technical terms. If you see a patient has something called diastolic dysfunction and you'd want to do a further confirmation, this has something called the tissue Doppler, and it can do a better assessment of now the diastolic dysfunction, and you can be able to do that. And then also in terms of memory and what you can retrieve. So from this machine, you can retrieve so much data as far as 6 months ago, 1 year ago, that was done on a patient, and it will be complete from the biodata to the imaging to the videos, because it has the capability of even recording videos and the images as well. Yeah.
And I'm looking at, in terms of the sizes, how portable now is this digital one?
Yeah, now this one, you can actually remove this part, this upper part that looks like a computer, and carry it. We actually go with it in bags. So if you see the cardiologist marching into your hospital, your clinic, you'll see us dragging bags, the way people drag bags in the airport, yeah? So this one can be removed from here, and this one left behind, and then we just carry this and the charger. So if I wanted to go and do an echo in Isiolo, for example, if we have a branch there, we have a branch in Meru, so we carry that to just help us to do more. Even though the branches have their own, but this can help do more. So it's quite portable, and yes. And as well within the facility, because I wouldn't be moving with that whole thing to accident and emergency and probably have an emergency echo that I need to go and do ASAP. This will move quite fast, and it's better even in terms of it will go and occupy less space and allow the other works to continue. Yes.
Thank you so much for the insight, Carol.
You're welcome.
And I hope you have learned something at home on the different generation of the echo machine. That is it for our technology and medicine segment. Thank you for staying with us. Just before the break, Carol took us through some of the tests done to diagnose irregular heartbeats, and especially the Holter, the use of the Holter monitor. Did I say it right, Doc?
Perfectly.
All right. Now, after getting the data, what next?
Thank you, Sheila. And again, welcome to the Current Hospital. We've just gone through how to fix a Holter recorder. A Holter was actually the name of a person who first described this process. It's nothing more than a 24-hour or even longer, can do 48 hours, 72 hours, recording of the heartbeat. For example, when you come and you say you have an irregular heartbeat, we may do an ECG at rest and put you on the couch there and do a recording of your heart. At that particular time, which is less than 1 minute, we may find that your heartbeat is normal. The fact that it's normal that time does not mean it's normal all the time. So we can miss it. Because of that fact, first person called Mr. Holter, or Dr. Holter, invented a longer duration electrocardiogram, where you carry the electrical cardiogram machine home and it records your heartbeat regularly. The time you are leaving hospital, when you get home, in the evening, when you're having dinner, when you go to sleep, you sleep with it, you wake up in the morning, it's you recording, and it can record heartbeat for continuously 24 hours. As I say, you can extend it even to 48, even to 72 hours. Then you bring it back here. It's a small chip. The current ones are very small. You can see how small it is, this recorder.
Yes.
This is what you take home. And these are the stickers that you stick on your chest. It's under your gown, under your blouse, under your shirt. You go home with it. It will draw an ECG continuously for that duration of time. All that information will come stored up in this chip inside this little computer. It's when you come now that we download it on our screen.
Okay.
And we go minute by minute, second by second, to see exactly what your heart looks like. And then you draw a pattern like this. Each of these small spikes is a heartbeat. And we have thousands and thousands of them. And we can choose any space that we want, and we will magnify it and see how it looks like.
Okay.
And then we'll see the pattern of the heartbeat. If it's regular all the time, we are happy. Sometimes we see extra beats. They become singles, in doubles, or they may be extra for a minute or even 5 minutes, irregularity. So we can see the irregularity, and these irregularities are treated differently. There are times that you get those irregularities to a point where the heart is affected because it's beating very fast. It has no time to fill with blood to pump to the brain, and you pass out. We call that syncope. You pass out because there's no blood going to your brain. That's a dangerous thing because it can lead, sometimes you may faint and not wake up. Depending on the pattern we see here, we shall then tell you what type of gadget you need to control your heartbeat. There are gadgets that control irregular heartbeats. There are gadgets that control fast heartbeats. There are gadgets that control slow heartbeats. For example, if we come and we look at the pattern where you are, and we find that you are going at a rate of 40 or 35,
Okay.
that is very slow. That's the time now we recommend that you get something to quicken your heart called a pacemaker. And there are various types of pacemakers. One that just control the heart rhythm, they quicken your heart when it's slow. The other that correct the heart rhythm. If you are going very, very fast, we do have pacemakers that can give you an internal shock. We call them implantable cardioverters, defibrillators, ICD. We put it under your skin, above the breast, and just under the skin. There's a small thread that goes to your heart to monitor the heartbeat. And they also got let's call it this, a current gadget inside that if you record that your heartbeat is too fast, we can give you an internal shock to correct it. You've seen in those movies, when somebody gets some heart problem, they put them on the couch and they have these big defibrillators on the chest, and they choke him and he jumps. We can have miniature ones that you put inside the heart that will shock you from inside and correct the heart rhythm. Keeps you from dying suddenly. We call those ICDs, or implantable cardioverter defibrillator. We can also have then the pacemaker that pays for heart rhythm, and have pacemakers that pays for slow heartbeat. These are the ones that most people know about because they increase the heartbeat. The only problem with that, Sheila, is that they're also a bit expensive, and but they're not more expensive than the patient.
All right. Now, does that Holter monitor also record noise from the outside, or it's just from the inside?
Oh yes, it can record electrical noise. But the good thing about these current recorders, they can actually detect that for you. They tell you that is noise. But even if they don't detect, we have a manual overlay. I have to go through this recording for the 24 hours, beat by beat. And I will decide which one is noise, when it's real. Because even abnormal heart patterns have a pattern. You get the pattern that has no pattern, then you know that's artifact. It's noise, it's not real heartbeat. The equipment that we have here can detect abnormal heartbeats. And we can tell the bad beats and the good beats. The good thing about bad beats is that even bad beats have a pattern. So if you find that the rhythm you're getting there has no pattern, you know, just the computer will know that it's an artifact, it's not real. But it helps us to read on that equipment how your heart is behaving for a period of 24, 48, 72 hours. In fact, we can even study your heart longer, even for 6 months. Say, for example, you've been fainting, and we put this recorder for 24 hours, 48 hours, you don't catch any abnormal heart rhythm. It does not mean it's not there, because it means you have not fainted for those hours.
Yes.
But you could faint after a week or a month. So we can give you a recorder that records for 6 months. But that one we cannot stick on your chest, because it means you don't have a good shower, you not swim. What we do is we put it under your skin. Just above the breast, we make a small nick, and we slide it there. Just like we, things for family planning that we slide under the skin. We can put it under your chest. It will continue to do your ECG continuously every hour, every day, every week, every month for 6 months. And you can read what it's recording. You don't take it out, you come with a remote control, and you can read what does my gadget say. Oh, I saw this. Or you'll faint, then we'll read the time you fainted, what was it recording. So you can get an idea of what causing the symptoms of fainting. The Holter is mainly useful for fainting, dizzy spells, those episodes of where you go near fainting. The Holter helps us, as is a 6 month recorder. We call it the loop recorder.
What would you look out for in the data?
In the data, we read how many beats per minute.
Okay.
Are you at times going at the range of 35, 40, 150, 300? So depending on the speed on the recorder and the pattern of those beats, we can tell you what the issue is. So we can tell about speed. 2, we can talk about regularity. Those beats, are they regular? We can tell. 3, is there times that the heartbeat does not come through? Because heartbeat starts on the upper chambers of the heart called the atria and come down to the ventricle for the ventricle to pump. That conduction system can fail. It can sometimes not get through to the ventricles. So the heart rate drops significantly, and you may have somebody going at a rate of 30. And therefore they either feel faint, or when they try to exercise, because they can't raise their heartbeat, they become very breathless and very easily tired. Those are the ones that we give a pacemaker. There are other conditions we can pick from here of those very fast heartbeats. But the heart is going at a rate of 150 plus. Doesn't kill you, but makes you feel very fainty. We call it, in the medical terms, supraventricular tachycardia. It's coming from above the ventricles, so that's why it's called supra. The tachycardia, because tachy means very fast. So you can get and people, that's very common, where people come with a heartbeat of and they feel very uncomfortable. They can correct itself. Sometimes you have to come to hospital for us to give you dawas to correct it. But there are other newer systems where, because we know where that current in the heart is passing through, what we said about the heart, this heart, that current, we know the pathway where it is passing through. We can find that is coming from the top here and has many other pathways. It can take a shortcut that goes into other areas of the heart. We call them bypass channels. And there's a new, not so new, but new in this country, a new system where we map out where those currents are passing through. And once we know where it is, we actually burn it from outside and make it disappear so that you don't have those short-circuiting. We call that ablations. That's some treatment for a long time we were unable to give here in the country. We have had to send patients either out, or we get teams that come with equipment to help us do those ablations.
And in terms of the age groups, and also in terms of women, men, children, who are the most affected with regard to irregular heartbeats?
With the irregular heartbeat. Irregular heartbeats, by the way, Sheila, they are in all age groups. because there are different types. There are those people I tell you have abnormal pathways, those you are born with. So those are the kind of younger people. That's why you have seen footballers going to play football. They were perfectly fit, they can play football, and then he falls in the field.
Yes.
Because this system of electricity has gone bad. And all of a sudden, instead of beating regular, it just goes zzz, and the heart ceases to pump. Those ones are in young people. Those arrhythmias are the ones that are controlled by doing those what we call ablations and things like those. Then there are those ones that come because you have had a bad heart circulation. For example, people have had heart attacks, for example. That heart attack, when it damages the muscle, it also damages those currents, those wiring that conduct electricity. So you do get heart blocks. Those are common in older people because they are wear and tear. But heart rhythm irregularities, abnormalities are common in all age groups. Yeah. But not all of them are dangerous. It's good to reassure people. And the fact that you have a palpitation does not mean that you are near death. No. There are some palpitations that are safe. There are some palpitations that are not safe. That's why it's important to get the 24-hour heart rhythm recorder to show you which one you belong to. At the same time, assess your heart with an ECG and an echo and maybe an exercise test, whether you have any other disease in the body.
So my heartbeat can be regular, but it's not dangerous?
Absolutely. Most of the heartbeats that are irregular actually are not dangerous. There's one condition we call atrial fibrillation. Not life-threatening, but it has risks because when the heart is not beating well, it's irregular. These upper chambers, they are not contracting. If blood stays in here too long, the tendency of blood is to clot. Anytime the blood stops moving, it will clot. If you put blood in sufuria, it will clot very quickly. But if you get a kamwiko and keep stirring it, it stays liquid longer. So motion and movement of blood is important to avoid blood clots. Anytime blood does not move quickly, it will clot. That's why if you go on a long journey on a plane or a bus ride from Kampala to Mombasa and you are sitting still and your legs are not moving, the blood there stays too still, it will clot. That's why we get blood clots in the calf called deep venous thrombosis, DVT. It is a consequence of staying too much in one position and the blood not moving. Same way in the heart. If the blood not moving very quickly, it forms a clot. And you have that irregular heartbeat called atrial fibrillation. The heart does not pump well. The blood stays in the heart, especially the atria, for too long. They form little clots. They don't have to be big, tiny ones. But once they move out of the heart and they go to your brain and they block a little vessel there, it becomes a big issue because every tiny vessel in the brain is important. And if you block any of them, you get a stroke. So people get stroke from irregular heartbeats, and that's why it's important to analyze those type of heartbeats. Because if it's that type of atrial fibrillation, you need a blood thinner for life.
All right. Now we've been talking about prevention is better than cure.
Yeah.
Are there ways that I can prevent irregular heartbeats?
Absolutely. Prevention is not just better than cure, it's cheaper. Cheaper than cure. Yeah, because you can prevent it. You can predict it, you can prevent it at a less cost. And the most important thing is to find out what causes those things that give you irregular heartbeats. The majority of cases, there's nothing you can do about it. Because if it's a system of abnormalities of the pathways in the heart and you are born with, there's nothing you can do about it. Those you are born with, they have been investigated. Like I said, we'll bring that equipment end of the year that that measures and those pathways. And if they are there, we can burn them and ablate them. So if it's congenital, if you're born with it, it's shauri ya Mungu. We find it, we treat it. But there are conditions, others that are earned in life. One, of course, is what you have said about traveling. If you are going on a long journey or taking a long flight, don't sit still. Even if in the plane, just get up, walk around, stretch your legs, keep yourself well hydrated. If you are a passenger in a bus from Kakamega to Mombasa, in between, just stand up, stretch your legs, and even when you are seated, keep pumping your feet, keep moving your feet to avoid that long stasis of blood in the veins. Of course, the blood will stay in your legs longer if you have excess body weight. So weight loss is also very important. Not to mention, have your sugar well controlled, your blood pressure, and don't smoke.
All right, thank you so much for having us, Doc. We have learned so much from you, and I hope you at home has learned as much as I have here with me, with Dr. Gikonyo. Thank you for joining me. I am Sheila Chelangach. Do stay tuned for next week.